We're off to a good start if I can remember to record all on my own. What's that? Yes, I do. Okay. Yeah. Okay, you guys, there was a question on the calendar about Skills Olympics for Wednesday, and I got it clarified. It is only 1 hour. So you have the face-off between the winners of yesterday's points and the winners of today's points, and then they face off on some other skills on Wednesday, and the other teams that didn't make the final round, I guess, are the cheerleaders. You get to cheer them on. So yeah, you bring your pom-poms, whatever you want. Okay, and then I usually try to do a little bit of a Q&A on Friday morning, and I'm a hard copy planner girl and in my phone, and I didn't have my planner with me. So initially just think about Friday morning at 9, but I will watch your Canvas announcements, and I will let you know yay or nay what time. And we'll try and do a quick little ECG Peds Cardiac Q&A for about 15-20 minutes, okay? All right, so we are going to start the Peds Cardiac piece that I had hoped, good morning, that I had hoped to do with the little video that wouldn't start. Yeah, my whole Peds Cardiac presentation, I don't know, it's corrupted or something like that. Thankfully, it's only like 3 slides or 4 slides long, and I can remember what they are. I've done them long enough, but I had to put it all back together again. We have a shared drive here, and it was corrupted, and then on my laptop it was too. So I don't know what happened there, but we have, let's see here, got a little video that was going to initially start. Come on. That has regular fetal circulation. That was going to initially start off our presentations. Why is my screen sharing not my presentation? Well, for heaven's sakes. And then I undid it because I have to share my screen. Let's see. I have to share my screen for them to be able to see it.
That's so true. That's all
All right, so we're sharing. Okay, can you see that on there the way that it's supposed to be?
Well, it shows like your section, like the next
Oh,
slide.
okay, yeah, the next slide. Okay, that's okay. That's okay, but you can see the chat, okay? Okay. All right. Okay, so here is the little video that reminds you of fetal circulation before we messed it all up with all of our cardiac disorders. Oops. Oh, heck, hang on. Where did it go? Oh.
If you do the second verse, you're awesome.
I need part of it. I forgot.
Okay, let's go back.
Cassie Cassie wrapped this at her sister's wedding.
Did she? Oh, does somebody have their microphone on? Oh, okay. All right, let's try again. This is your fetal circulation. Hi, Vic. Do you need me?
I don't do. I'll be yeah.
You know they're recruiting this show? They're recruiting the president. Yeah, they're making it like a drama. I don't know. Still is.
Yeah. Oh, yes.
Like, even when I'm not in school, like, I'll take a look.
Yeah.
Oh, it took some time. The APs and the different stuff, yeah. We're coming up with like rhymes. I don't know.
Yeah. Just a little one. Making it kind of
Okay. Let's get. Okay. One thing can you see this on the big blue button? And me too?
Yeah.
Sorry about that. Okay.
It cuts off like this, or not this off, but this like more of the screen. So if you want to turn it a little bit more, it'll come in like a full screen.
That way?
Yeah.
Okay. How's that?
A little bit more.
Okay. Okay. So prostaglandins are given to keep the ductus arteriosus patent, or to keep it open. So when I was in nursing school, I learned a really horrible way to remember this, and I always pass it on. So please don't be offended. Prostaglandins keep things open, just like a prostitute would keep things open. I had a nursing instructor show me that, and I never forgot prostaglandins. Because prostaglandin inhibitors will close things up because someone is very inhibited. They're very closed up. Okay? So on your PDA, if that is your only heart anomaly, is your ductus arteriosus being open, it will give prostaglandin inhibitors to close it. If you have some of those big heart defects like tetralogy of Fallot and AV canal defect and all of these kind of mushy mess things in the middle of the heart, they need that ductus arteriosus open. And so they will give prostaglandins. That way they have a way to communicate blood flow from the lungs to the body. Okay? Crazy thing. All right. Why won't it? Oh my heck. None of my buttons work. Any ideas why none of my buttons will work? I double clicked the little pad. I have no idea. You just start pushing stuff, right? And then it goes. Okay, your cyanotic heart defects. Here's a way to remember, hey, all of your T's, all of your T defects. So truncus arteriosus, there is one trunk. Transposition of the great vessels, there are two vessels that are transposed, okay? Tricuspid atresia. Tetralogy of Fallot, we'll go over that one in just a minute, but that's your four, there are 4 heart defects in that. And TAPVR, there's 5 initials, total anomalous pulmonary venous return. So all of your T's. What?
Or the D is 5.
That is true. D is 5. Okay. And then down here at the bottom, dang it, this little thing keeps being way in my way, no matter where it's at. Okay.
Oh, click hide.
Yeah.
But then will I be able to stop sharing at any point?
We'll figure it out.
We'll figure it out. We'll figure it out. Your only other 2 that are cyanotic, like at rest. So when I say cyanotic, I mean at rest. That baby looks dusky, kind of bluish, kind of mottled before they start crying, before they're upset. There are other heart defects that are not your T's and not your pulmonary atresia and HLHS. So you've got peaches are healthy. Pulmonary atresia, HLHS. Those are the only 2 that are not T. Now your AV canal defect, this was something that was talked about after the fact, was that initially it is not a cyanotic heart defect because you have more of a left to right shunt and it's going out to the lungs. Now that extra blood flow that's coming from the left to the right and the body to the right, and it's all being shoved out to the lungs, will start to scar the lungs. And then they have buildup of pressure because they're scarred, and they'll start to push back. When they have that increased blood flow into the right ventricle, then you have mixing the other direction, and it will become a cyanotic disorder. And so they need to get that repaired sooner rather than later and not let AV canal go unrepaired. And because then you'll have permanent scarring in the lungs. So just remember that these are your cyanotic ones. Those are at rest. Even though other kids can turn a little bit bluish or dusky if they have a VSD and they're really upset, they're screaming and crying and they can get a little dusky too. And that was it. That was the peds cardiac one of mine. So then we'll go. So this is the presentation for tetralogy of Fallot. That would have been Aubrey's. So I created it last night. Who was it that told me about the slides go thing? Yeah. Yes. It was very late. It was very. I don't feel bad for you. You had more advance notice. All right. So tetralogy of Fallot. There are 4 heart defects, hence the tetra. One is pulmonary stenosis, right ventricular hypertrophy, a VSD, and an overriding aorta. So you can kind of see it here. I made it bigger so that you can see right. Oh, they can't see that light on there. So right here, number 1 is your pulmonary stenosis. It's thickened and it's narrow. And so the outflow flow to the lungs it's difficult. It's difficult for that right ventricle. So it is going to work really hard and end up having this thickening of the wall and hypertrophy. When it starts to hypertrophy, it actually can get bigger, look bigger on a chest x-ray and get a little bit bigger because of the thickening of this wall and the left ventricle. That can start to cause kind of a boggy heart muscle, and that hypertrophy can start to cause heart failure if it's not fixed. Then number 3 is a ventricular septal defect. So you have a VSD right there through the ventricles and an overriding aorta. So instead of coming right from the left ventricle, kind of up this way, it sits right above that VSD. Because it sits right there, it has mixed blood that goes out to the body. And that makes it a cyanotic heart defect. It will be kind of dusky and kind of blue, sometimes look a little bit mottled, because that is coming right off there where that mixing is happening. All right, so your clinical manifestations, pretty much the same as everybody else's. All your little heart defects have poor feeding and failure to thrive, shortness of breath and increased work of breathing. Sometimes they'll have grunting. So this one's pretty profound. And they do have a number of surgeries that they need to correct it, several steps of surgeries. They have the cyanosis. They're easily fatigued, especially with feeding, if they've been crying, if they have had once they've had a bath and they've been awake for a while and they've just been very active, they can be really easily fatigued. They're very irritable. The clubbing comes later. So in an infant, you will not see clubbing. That's a later sign of poor circulation. The youngest I've seen it is 4, but I didn't do hearts all the time. That was in float pool, and I saw hearts a lot of the time. Does that make sense? So somebody may have seen it a little younger. Just remember, you will not see it in an infant. They haven't had enough time for that damage to happen. And they look a little bit like ET fingers. They're kind of fat on the ends. Cool and mottled extremities, and then they have a boot-shaped heart. So if you look at their x-ray, it looks a little bit like a boot. And it's because of that right ventricular hypertrophy, and it's bigger than the left ventricle. So it makes it look like a boot. All right, so your diagnostics and your repair, chest x-ray, like this. They see that. They can not definitively diagnose it, but that is a big cue for them to look further. CCHD. Who knows about CCHD testing? Okay, tell me.
It's when babies are born and then for 24 hours of care, they get hooked up to the pulse box, put it on their right hand and their foot because this is the lowest confusion. And you see how well they're oxygenating their body, and you have to pass that test sitting in the usually before they can go home.
Perfect. So I just realized they can't hear. Yeah, I heard you. Very good. So in the first 24 hours after a baby is born, they have this, basically it's a pulse ox test. And they put a pulse oximeter on their right hand and either foot. And because you have less oxygenation in this hand when you have, when you've oxygenated, oh my gosh. When you are circulating, you have lower oxygenation in your right hand. And they have to pass that. There's a certain percentage that they can be different, right? I don't remember the percentage, but there's only a certain percent that they can be different on their right hand and either foot. They have to pass the test before they go home, and usually it's in their car seat. And that is actually becoming a law in many states that kids, that infants are tested, undergo CCHD testing, and it's critical chronic heart disease. Yeah, critical chronic heart disease is the CCHD. And they can do an echocardiogram. They can see the blood swishing and moving everywhere, and the outflow tract of the pulmonary outflow tract is very limited. They can see the hole in the VSD. You can see the overriding aorta. and they can see all of their cardiac output. So an echocardiogram is very good and diagnostic. They can have TET spells, and what that is, if they start crying or they get really upset, they'll go really blue. And if you help change the pulmonary pressure by taking their knees and just lightly pushing it to their chest, it increases that pulmonary pressure and helps them oxygenate better. If they're a child that hasn't undergone all of the repairs, you will find if they walk, that they just, when they start to feel like this or they get upset, they start to turn really blue, they will squat. And they'll just squat right down, and it changes that pulmonary pressure. And so that's something to educate your families on, that if they see them doing that, they're having a difficult time breathing, having a difficult time oxygenating. So if you have an upset baby that has tetralogy of Fallot and they're turning really, really blue on you, then grab their little shins and just kind of push their thighs up to their chest, okay, with a little bit of pressure. And then surgery is required to fix it. Several steps of surgeries, which you don't have to know all the names and everything, just know that surgical intervention many times is needed. Are your nursing implications? Vital signs with continuous oxygen saturation monitor, and then oxygen PRN. They don't have to have a ton of oxygen. They don't push heart babies up over the 90s very often. They're very good to sit at about 88, 89. It doesn't tax their heart as much if we're trying to oxygenate and have them keep their sats much higher. They're very okay with them sitting right there in about that 88 range. Small frequent feedings, because they don't tolerate like long feedings, lots of formula, or breastfeeding all at the same time. They used to say that breastfeeding was too hard for them and to not try to breastfeed if you have a baby that has a heart defect. The American Academy of Pediatrics, the American Heart Association, and several other entities did research and found that the babies, if they're small frequent feedings, do very well. And it's just fine for them to breastfeed. Higher calorie formulas. So sometimes they might have to supplement those breastfeedings with a little bit higher calorie formula. Or they can protein pack it. They literally have baby protein powder that they can put in their formulas. And then knees to the chest during TET spells. Cluster your cares. If you go in and you do everything you can do for this baby and then get out and let them rest. Let them rest as long as they can. So if they're awake to feed, take their vital signs. The only thing that I wouldn't do is if they have just fed, that's pretty taxing, don't give them a bath, because that's taxing too. And so if they were awake and they were feeding and then they had slept for a while and you had to do vital signs, then you could do vital signs and give them a bath. Okay. Low stimulus, try and keep it quiet, a little bit darker, not a lot of people in and out, so that they can rest and so that they don't have a lot of stimulus keeping them awake, keeping their energy up. And then educate and support your parents. It's pretty hard to have a kiddo that has a heart defect. Everybody that finds out that they're expects to have this nice, healthy baby. And then when they're born and they have a heart defect that's pretty profound, that's pretty scary. And then you're supposed to leave this at the end of the slides go so they get credit. So that's all that one is. Okay, questions on tetralogy of Fallot? No. Okay. Was there any online that? Oh, that's right. So I was trying to think last night. I was like, what the heck do I do for a learning activity? I don't even know. So I thought, maybe I'll have you guys create a test question off the information that I just had. So tell me how you would create an NCLEX style test question for that information. So maybe if you'll watch the chat for me and see if people start coming in with ideas too. Yeah, so come up with distractors. Okay. Okay, so your child is having a TET spell, and they're turning very blue. What would you do as a nursing intervention? So what's your right answer? Knees to the chest.
Yeah.
Okay. What's a distractor? Call the physician. Okay. Increase oxygen flow. Semi-Fowler's position. Yeah. Tag them. Right. What did you say? What did you say? Yeah. Semi-Fowler's. Yeah. Prone. Put him prone. When Jody was first brand new, I was her mentor and we were writing some test questions. And I think she still has it in her test in 05, but it's about a hip patient and ways to position them or ways to, and so you don't abduct that hip or, and one of them is lay them prone for so many hours a day. We thought that was pretty hysterical. And people picked it. We're like, no, do you remember what prone is? You do not want to roll a hip patient on their face. Don't do that. So, okay. So good test question. So we try to come up with those and come up with feasible distractors. Like you don't want to say, blow their nose or place an NG tube or things that will not be picked. Does that make sense? And so we look at our distractors too when you guys take a test, and we look at our statistics and see what needs to be tweaked or changed or dropped. And then we also look at our answers. And if 0% selected that distractor, it was not a good distractor. And if you had what? And if you had more people choose the wrong answer than the right answer, then that still is not a good distractor. It's too close, or it wasn't clear in the lecture or something like that. So if you had the right answer, it was only picked like 28% of the time, but one particular wrong answer was picked 50% of the time, then we will go ahead and drop that question too. That's part of our policy. And then we look at revising that. So 0% or too many that are wrong, then those aren't good test questions. So they're hard to write. They take us a long time because you got to look at it and make sure, was it covered in lecture or in the book? Because I can't go by my experience, right? Because that's not something you would just know. And so it has to be covered in the book or in the lecture, and that's why we have objectives. So it keeps us in line so that we write right to what the test is supposed to be. Okay? That's kind of how that works. So you guys did a good job. All right. Let's do... What's that?
I learned something today.
All right. Bacterial endocarditis. Miss Jess Carter. I love this, that she says an amateur presentation thanks to Google and YouTube.
My mom didn't think it was funny. She's like, put Google Scholar on there.
There you go.
Because I still live with my parents, so
Well, when you're a student, I think that's not a bad idea. All right, so that goes forward, that goes backwards, and that's the pointer you need.
Okay.
Okay, you guys, listen up.
Okay, so I'm gonna be doing bacterial endocarditis, which is kind of, I picked the same theme as everyone yesterday to kind of keep everything continuous. So, okay, I had to look on YouTube for an explanation of what this is because it's so rare that there's like not a ton of information out there, but it's like really fatal because of how rare it is. It's not often caught. So I had to look on YouTube, and this guy had this amazing YouTube video. I linked it at the end here, but it was like 2 minutes. It was 10 minutes long, so it's too long for me to put in. So I just cut some pictures out of it. So hopefully I sourced it right because I used like a ton of his stuff. But just to start, endocarditis is exactly what it sounds like. It's an inflammation of the endocardium of the heart. So I've got the layers of the heart up here, and we're talking about this inner layer, the endocardium. So this is like something that they don't really know why it happens, but turbulence of the blood flow causes the lining, like the epithelial tissue in there, to like break down and expose that fiber and collagen. And then that causes this kind of platelets to come and form this clot in the lining of the heart, which is good and a good response until we get bacteria that's exposed to this tissue. So the way that bacteria gets exposed into our blood, they've actually found for like bacterial endocarditis that a lot of times it comes from like dental procedures, which is weird. Or like if people brush their teeth too hard and make their gums bleed, or they floss and they get bacteria in there. It can also come from our gut and our lungs, which I feel like are a little more like normal ways to think of bacteria entering our bloodstream. But these bacteria really like the platelets and the fibrin. So they'll actually attach to it, and they will create this biofilm, and then they'll create their own matrix around to attach and create like this, I don't know what's a biofilm, but like a glob with bacteria and platelets. And then the problem comes when this breaks off and travels, because that turbulent blood flow kind of causes them to break off, and they don't like to sit there. They want to sit in a spot in the heart where they're not going to be disturbed. So they usually like to go and sit right by the valves. So I've got on here kind of, again, those open wounds, how you can get. With peds, we're not really too worried about the infected needles, but I put it in there because it's kind of a big part of it. That's a big part of how infection can get in the heart. So the valves that are most often involved in this are on the left side of the heart. So our mitral and our aortic valves over there. And they'll break off from the lining, and they'll come and they'll sit on like the part of the valve. So this is like the blood flow coming up from the ventricle. They like to sit either like right here on this part, or on the other valve the same way, where the blood's not kind of hit them. So they don't like to sit here where that turbulent blood flow is. They like to break off and kind of float down and sit right here, because there's not a ton of pressure on the sides of the valve. It goes up and it doesn't hit them if they sit right here. But then they kind of make the valve boggy, and that is what we are worried about with the bacterial endocarditis, is how they affect the valves and our heart functioning. So anyway, his video explains it way better than I did. That's kind of like my kindergarten version of how bacterial endocarditis works. And it's nice that we learned about all of those other heart conditions yesterday, because this tends to affect people that have all of those congenital heart defects that we talked about. So your risk factors, and that picture got really blurry, but this is just a heart kiddo. So if somebody has had to have a prosthetic valve put in place, that makes them more at risk. For some reason, those prosthetic valves just don't hold up as well. If they have any of those thousands and thousands of congenital heart diseases that we went over yesterday, if they have a rheumatic heart disease, which is they get like a rheumatic fever, and for some reason when they get that fever, it causes tissue breakdown of the endocardium. And then intravenous drug use, which again is not too applicable to peds, or if they've ever had a heart transplant. For some reason, again, I think on our little cheat sheet paper, if anyone's like filling out theirs on the bottom, I think it says like the cause is unknown, but they think it's an autoimmune inflammatory response. And so they think that maybe that's why it happens in patients that have already received like a transplant, because it's not an immune response, but they still aren't really sure. So the signs and symptoms for this one are actually really hard. So they get a fever, and the key is a new heart murmur. So something's going to change. If they've already had a heart murmur, something new will pop up. And that's just because, you know, that bacteria sits on the heart and bogs it down. It's going to create a new sound. But they have those septic emboli, those little biofilms, will break off from the valves too and float throughout the body. So those can be signs, but that's kind of like a later sign of the disease. So these are splinter hemorrhages where they're in the nail. I hope everyone at home can see what I'm pointing at. But the nail picture, these are called splinter hemorrhages. These are those biofilms that have broken off and embedded themselves in the nail. The hand one I've got, these are Janeway lesions, so they've embedded themselves in this tissue in the hand, and they just kind of look like little pinpoint pricks on the hand. These ones are osseous nodes. This is what it would look like if you looked in someone's eye, and they had embedded themselves there. And the raw spots are the really, really bad, where there's a lot that have gone and broken down that skin on the hand right there. So the murmur that you're going to hear is, of course, going to depend on which valve is affected. So you could hear it here. You would hear it over the mitral area. But if it was on the aortic, you would hear it there. And the thing with this one is it could happen gradually. Like they could gradually get a buildup of bacteria there, or they could have like some kind of fever and all of a sudden develop this bacterial endocarditis and have the signs and symptoms. And I've got that point in there that the cause is not known. So our nursing implications. It's important, and of course, if we've got our cardiac kids, to not get like complacent about listening for their murmurs and listening, like if we're used to hearing certain things, not just assuming that it's always going to sound like that, listening for those new murmurs to come up, checking their skin and nails, doing that full assessment to see how the function of the heart is changing. I think too, with this one, it's, again, I just keep saying it, but it's so rare that it often becomes fatal because it's not caught fast enough to intervene and save the life. And so if you are even kind of suspicious of it, you got to be your patient's advocate and let the doctor know, like bring up bacterial endocarditis and ask them if they think that's what it could be. The other thing we're going to talk about is a huge one in this is being prophylactic about care. So with our risk populations, providing prophylactic antibiotics before they get dental work or before they get surgery, just to cover our bases. And again, be an advocate for you and your patient. So the way they would diagnose this is with the bacterial, they would do blood cultures and grow. And that's actually the key in like curing it, is figuring out what kind of bacteria is causing the problem, and then they can give antibiotics for that. There's also an endocarditis that's caused by a fungus, which wouldn't show up in cultures. So that's why the way to know for sure is to get an echocardiography, an ultrasound of the heart. And you can see the vegetation growing right there. So that's how you can know. And if it gets really bad, then it would need surgery. So if their valves aren't functioning anymore, or they're having heart failure, so they come in those advanced stages, then that's when they would need surgery. But most of the time, if they catch it early, you can do antibiotics, growing those cultures, figuring out which antibiotics will treat it. And like I said, prevention is really the big key. So keeping these heart kiddos at low risk, giving them antibiotics before they go in to get procedures done. This is that link I was talking about. He takes like 3 minutes in the middle to talk about like the different kinds and what different germs cause bacterial endocarditis. So you can skip that, but just to understand like the pathophysiology of it, I loved this video. And then I told my mom I used a journal for my source, and I really did use a good source. It wasn't just Google. So
It wasn't just Google.
That's a good source too. And for my activity, if you're in class, I want you to just turn to someone around you, tell them something you learned about bacterial endocarditis. And if you're at home, you can chat in the chat box about it. It was hard for me to think of a question because all like the signs and symptoms, they just weren't very like conclusive too. So hopefully this is okay.
Yeah, so take a minute and maybe just tell all of us something that you learned.
So I had a patient that I did my care plan on
Uh-huh.
a while back at and the patient comes in because he had stomach pain. He had like 9 out of 10 pain, he was throwing up, like they had to take him emergency. And they said he had splenic infarct because he had a septic.
Oh.
And he did have a heart valve. He had a Ross procedure when he was younger and stuff. And like hearing his heart was amazing. Like, it was so cool. But I did his assessment and he had a whole really?
Oh.
And I remember that because I asked the nurse, I'm like, I didn't know how to charge it. She goes, oh, wow.
Really?
Okay. What is it called again? Nails?
Splinter hemorrhages.
The splinter hemorrhages, yeah.
Yeah, like his nails were all like that, but like much worse. Like,
That's
Uh-huh.
crazy.
like,
And then they had a septic emboli that probably broke loose.
and they
and
had
lodged in the spleen.
officially diagnosed it as endocarditis, but they said possible.
Uh-huh. Very likely. Wow.
I thought that was so interesting. And I was
Yeah.
like, well, do I do my care plan on this or this?
Uh-huh. Yeah. Oh, that's very cool. It's nice to see it in practice.
Yeah, and that's the thing too, is it's so rare that it's like people don't even know what to look for.
Yeah.
So,
Yeah.
anyways.
Good job. Good job. Give her a hand. That was one of the best explanations of bacterial endocarditis that I've had. So that's very good. All right, Kawasaki disease. Mr. Mark. Mr. Mark. That goes forward and backwards and a pointer. Okay. Give him your undivided attention.
I can speak over you. All right, so I'm doing Kawasaki disease, and like the bacterial endocarditis, it's very, very rare. So we're just going to go over what it is, how is it treated, and then what is our role as a nurse when we're looking for signs and symptoms, and how do we treat these kids. First off, what is it? It's considered an autoimmune disease. The cause is unknown, so that's a risk factor in and of itself. We don't know, like some other diseases, we're not necessarily looking for something like this. They're going to present with a lot of signs and symptoms that you'll see in other things. What Kawasaki disease does, the effect that it has on the body, is the blood vessels in the body swell, they become inflamed. It's called vasculitis. It also affects mucous membranes, so it'll cause things like dehydration. It directly affects the heart by causing coronary artery aneurysms, leakage in the valves, and buildup of fluid around the heart. And that's really bad in the short term and the long term, especially if you don't catch it. These aneurysms can build up and rupture. These blood clots can also surround some of the vessels and then cause problems later as well. Most commonly seen in children under the age of 5 or 6, but it's mostly in kids under 2. And I believe like 95% of cases are going to be children under the age of 10. So that's what you're looking for. Some of the signs and symptoms, you're going to have a high fever, rash, redness and swelling of the hands, followed by peeling skin on the fingers and toes. Bloodshot eyes without the drainage. So they'll have like these red eyes. You might think of like pink eye, but there's not going to be a drainage. So that's something that'll separate those things. Red cracked lips. They're going to be really dry. Strawberry tongue, if you see like right here. Sometimes you'll get like little dots on it too, but yeah, it just really sticks out to you. It's bright red. Enlarged lymph nodes in the neck. So because the lymph nodes get enlarged, they also think it's sometimes considered a lymphatic disease. And how is it treated? First thing we got to do for them to get a diagnosis of Kawasaki disease is they have to meet the criteria of having multiple symptoms. They can't just present with like bloodshot eyes and like, oh, it's Kawasaki. They've got to have like 5 or 6 of these symptoms before they'll proceed with some of the other tests. You're going to want to get an ECG, an echocardiogram, get some blood tests. They're going to want to rule out some other things. So they're going to do viral tests, bacterial tests, and strep tests, things like that to rule out other illnesses because they present with a lot of other symptoms that many things that these little kids usually have, like high fever and treatment. They do intravenous immunoglobulin IVs. So what that does is it brings that swelling down in the vessels, prevents those aneurysms from forming. And it's really only effective if they can get it caught within like the first week to 10 days of that. Once they get beyond that, it's not as effective in preventing these aneurysms. And because of that, because it's an IV treatment, they're going to be in the hospital for a while. In some cases, so it could be like a week, 2 weeks until they get this IV treatment done and they feel confident that this kid's going to be all right. Another thing too, they're going to give them anticoagulant medications. Even though it's contraindicated in children, they're going to give them high doses of aspirin. That kind of
Benefit outweighs risk.
Yeah, the benefit outweighs the risk there because it's going to thin that blood because those clots are going to be forming like really quickly. So one of the things that they're going to be looking for too, because these kids will go home on a prescription of high dose aspirin as well for 6 to 8 weeks. If they come in contact with things like chickenpox, it has a really, really bad effect. So they're going to have them like stop the aspirin, maybe get them on like Coumadin, something like that, to help thin the blood that doesn't react with chickenpox as bad. The long-term outlook, usually it's pretty good. You know, a lot of these kids that have Kawasaki disease, even if they don't go to the doctor, they end up being okay. But if it gets to where it's causing clots and aneurysms and they get it treated early enough, the outlook is really, really good. And that's because they're going to have follow-up appointments with cardiologists for 6 months to a year to a couple of years, depending on the severity. If they get any aneurysms or any coronary blockage, that depends how long they're going to be seeing cardiologists for. And if they catch it really early and there's no heart involvement, I mean, it's really, really, really good outlook. So as a nurse, things that we're looking for hyperthermia. Their fever is going to be super high because the body's like, what the heck is this going on? They don't know exactly the mechanism of action, why these things are happening to the body. It just does. But when we look for hyperthermia, the skin degradation, like I said, with the hands, they're going to get really dry, cracked, peeling, red. And you're going to see rashes, usually kind of like in the lower abdominal area. Decreased physical mobility. These kids are going to have joint pain. Just kind of, like I said, they don't know why, but they're having joint pain. Dehydration, because those mucous membranes are being affected. So they're experiencing pain. Anxiety, depending on how old the kids are. Like I said, they're going to have these like 5, 6, up to 10 years old, and they're sick. We don't know what's going on. They're getting all these tests done. Parents are scared, so they're going to have a lot of anxiety, and they're just going to be wiped out. They're going to be exhausted, getting all this stuff done, having IV treatments, being woken up in the middle of the night. And so we're going to go through our typical nursing process there and identifying these things. What we're going to want to do, one of the main ones is we want to control that fever. So whether that's through cold blankets, aspirin, whatever we got to do to get that fever down. So then we don't run into other issues like febrile seizures. And we're going to assess for skin breakdown. They have ointments and types of things that we can put on the hands because they're going to crack and they're going to be dry. And so we can do as much as we can there to help them feel comfortable. We're going to provide oral care because like they're going to have that strawberry tongue, cracked, dry lips. So we're going to keep the mouth moist, the lips moist. Administer medications as ordered. So those IV treatments, aspirin, Coumadin, and if they have any other conditions, we'll address those as well. And we want to provide a comfortable environment. So dim the lights, limit the distractions. We don't want to be in and out of the room constantly, freaking these kids out. We want to make them as comfortable as possible, have some family there, provide cartoons and games and stuff like that. Assist with passive range of motion exercises because they're going to be in a lot of pain with their joints. Kids kind of typically, and I think just humans as in general, don't want to move a lot. So we don't want them locking up on us. They want to be able to get those range of motion activities going for them. I want to encourage them to eat and drink fluids because they may be having some throat pain. May not just be feeling well, and kids don't eat well when they don't feel well. So we want to encourage that and also to prevent dehydration. And rest is the big thing. We don't want them overworking themselves, keeping that temperature up, and wearing themselves out. Because for some of them, most of the cases, they turn out pretty well, but for some of them, if we catch it too late, it's going to be really stressful. So we want to keep them well rested. And when are our goals met? We're going to be assessing a lot. When our overall condition has improved, whether that's through our echo tests, doing ECGs, when the kid's looking better, because they're going to kind of look like garbage when they're going through this in a lot of cases. So when we see that their overall condition is improved, that's one of our goals that can be met. We want to make sure they don't have a fever for at least 18 hours before we send them home. We don't want to assume that because the fever's dropped down for a little bit that they're better and then we send them home and then it flares up or they've got other problems that we didn't see. And then we want to make sure that all the follow-up plans with the cardiologist and everybody else on the care team are finalized, and everybody's on the same page, that we understand what we're doing for this kid, and that the family and caretakers understand the condition and the aftercare. That they understand that they got to stay on this medicine, usually like the aspirin, we got to make sure that they're on it. And then also to teach, I didn't want to go too much into the teaching, because they said not to. But
Yeah, well,
okay.
yeah, no, that's
Okay.
fine. Most of it is post-op teaching, like heart defect
Okay.
stuff, but you've got good teaching here.
Okay.
So
Yeah. So what we want to teach the parents is like why we want to keep them on these medicines, because they're gonna Google stuff. They're gonna see like, hey, well, with them they could get what's it called, Rain syndrome with aspirin.
Oh, Rice syndrome.
Rice syndrome. And you got WebMD, Google, all that stuff. They're gonna freak out. They're gonna hear that, hey, my kid shouldn't be on aspirin. Why am I giving my kid aspirin? And this, you're gonna tell them why, and that they have to stick to it. That they have to meet these appointments. That they got to meet with their cardiologist, because this isn't something to play around with. You don't want aneurysms busting everywhere and causing bleeding and clots, and it's not good, especially for something that is very treatable. Right there, that's a big close-up of an aneurysm there. And so when they have this disease, if it's not treated, this is what starts happening in all these valves and or in these veins around the heart. And so why is our care, why is this instruction important? Because like I've been saying, if late and incorrect interventions can lead to future cardiac issues. And that's aneurysms in the arms, legs, kidney supply. So a lot of the vital organs, if we're not taking care of this right, or we don't catch it early enough, then they're going to have a lot of problems with these organs. Coronary artery enlargement, kind of the same thing. Blood clots, adverse drug reactions, like I was saying with the aspirin. We want to know these things. We want to know, hey, if the kids get exposed to chicken pox, then we've got to stop that aspirin, because we'll have an adverse reaction to that. Just a few facts of Kawasaki disease. They usually occur in late winter and spring in 2 to 3 year intervals, which is kind of odd. So it's not contagious, which is why this is super odd. But a lot of these things that happen with things that are contagious, or like pandemic type things. But they have these weird patterns where it happens every 2 to 3 years, where they see these outbreaks of it.
Kind of waxes and wanes.
Yeah, it's really weird. It is. It's like it just flows. Approximately 3,000 children are hospitalized in the U.S. annually. It's most frequently seen in Japan. They have about 5,000 to 6,000 cases annually. You'll see it predominantly in other places like Taiwan, Hong Kong, other places like that. 95% of the cases occur in children under the age of 10, and it happens more in males by about a 1.5 to 1 ratio. They're not sure why, it just does. And this is another odd one because it's not contagious, but those whose siblings are affected are 10 to 20 times more likely to contract it. That's why another reason they think it may have some kind of genetic disposition. They're not quite sure. So the big thing with this is when you see some of these signs and symptoms, and parents bring their children in with fevers and some of the other signs like rashes, and kind of being able to put that stuff together. That, hey, you know what? Now we're seeing 4, 5, 6 of these symptoms. Maybe it's something more than just that. So that leads me to our learning activity. What would you, when you see things like this, what are some other diseases or sicknesses that you guys would think that we would want to test for before diagnosing with Kawasaki disease? That measles,
Like you said,
conjunctivitis.
Another disease that causes like that shedding of the skin, the red and the shedding.
Yep.
What is it?
Hand, foot, and mouth disease.
Uh-huh.
That's a big one. That's the first thing I thought of. Which if you've ever experienced, that's not fun.
No.
That is terrible.
Like I said, viral infections.
Yeah, viral infections.
allergic reaction.
Yeah.
Yep, adverse react definitely with the rashes. Yeah. So those things that fevers, and you got all kinds of things that they could be. We got to rule those out. They're going to do strep tests and all kinds of other things. So.
When if they have a high fever and a rash like that, then sometimes they think meningitis, like meningococcal meningitis.
Yeah, so there's tons of other things that especially like you got to be really careful not to get honed in on one thing. Like, oh, if there's, maybe you got, because if you've worked in the ER, you'll see like you get kind of these rounds of things, like you get 6 kids that come in with the same thing, and you kind of just get focused on that. So you got to be really careful, even though it is rare. And that is it. And there are my references.
Perfect. Good job. Thank you, my friend. Okay. So real quick, because I told Vicki would be done right about now, and we still have our little answers to do. So let me give you the answers to the fill in the blank. And then I will give you a couple of things to make sure you remember about, like some of the different heart anomalies. All right, you ready? Number 1, this disorder has a classic sign of a lower blood pressure in the legs and higher in the arms. Coarctation, yep. This heart defect is characterized by the absence of the tricuspid valve. A VSD or transposition of the great vessels is often present also. Tricuspid atresia. An opening in the ventricular septum results in an increased pulmonary blood flow and is the most common defect in kids. It's a VSD. This heart defect is characterized by cyanosis that does not improve with oxygen. It is transposition. Yes, because you've got your circuits normally need to go like this, right? We're coming into the right, out to the lungs, into the left, out to the body. They need to be doing this kind of thing. But if you have transposition, then they're not crossing. So you've got, it's coming in through the right and out to the lungs and back in. So you've got 2 separate circuits because they're not crossing. They're not going out to the body from the left and out to the lungs from the right. Does that make sense? And so because if you don't have mixing, a way to mix your PDA, so that's vital that PDA stays open in transposition, because you will not have a way to communicate blood from the lungs to the body, okay, because you've got 2 separate circuits. All right, this heart condition is characterized by an inflammation of the lining, valves, and arterial vessels of the heart. So it's inflammation of the lining, the valves, and the vessels of the heart. Endocarditis. Yes. Oh, sorry, I didn't hear. You were behind a mask or something. Yeah. So endocarditis. That bacteria will cause inflammation of that endocardium. And number 6, an opening in the atrial septum that permits left to right shunting of the blood. Yep, atrial septal defect and ASD. The chest x-ray of this heart defect shows a boot-shaped heart related to a large right ventricle. Yeah, it's a tetralogy of Fallot. This Fallot, probably someone who's French that discovered that, right? This heart defect is characterized by the pulmonary veins emptying into the right atrium or by veins leading to the right atrium. Yeah, TAPVR. So total anomalous pulmonary venous return. So it is totally wrong. Total anomalous. It's pulmonary venous return, right? So our pulmonary veins are returning back to the wrong side of the heart, to the right side of the heart. So they come into the right, which is the wrong side of the heart. Most commonly associated with Down syndrome. Yeah. Well, no. AV canal. Oh, I'm sorry. I didn't hear. I thought you said an ASD, atrial. Oh, okay. Perfect. Yeah. Atrioventricular septal defect or AV canal defect. This heart condition is known for the heart atrophy and the heart's inability to be effective and shunt enough blood to the body. So think about if you don't have enough oomph to get to the body. So think of power on the left side. If you have a very, very small ventricle on the left side. No, so think about how small that left ventricle is. Hypoplastic left heart. Yeah. So you don't have enough oomph, basically, to get it out to the body, because sometimes they don't have a left ventricle. And other times it's this tiny, tiny little pocket. Let's see, the heart defect that is described as a single large vessel that empties both ventricles. Yep, truncus arteriosus. Okay, number 12 is a little tricky because it's already been said. This heart defect is the largest cause of death in infants due to congenital heart disease. It's hypoplastic left heart. It is also the biggest reason why they need a heart transplant. And many, many of them do. And then this heart condition is described as an inflammation of the connective tissue of the heart. Its exact cause is unknown, but it might be an autoimmune response in predisposed individuals. It's actually Kawasaki's. So there is a bit of an immune component, they think, bacterial endocarditis, but this is inflammation of the connective tissue. Yes. And the aneurysms in the coronary vessels, too, could be included in that. Okay, so that's just some of the little things that can kind of help you remember those. Some of the things that I've kind of made notes on to always make sure that I tell you guys, remembering that if it's more of a left to right shunt, so you have more power on the left, right? So if you have an ASD or a VSD, and that's your only defect, you've got more power on the left. You're going to shoot or shunt that blood to the right side, but it will also go out whatever vessel it's supposed to. So if it's coming in from the lungs to the left atrium and you have an ASD, it will go, some will go to the left ventricle, but some will also shoot to the right atrium and go back out to be oxygenated. So that's why it's an acyanotic heart defect, because you don't have, the mixing you have is happening on the right side of the heart where it's going back out to the lungs. And the same with a VSD. Some will come in from the left atrium to the left ventricle, and as that left ventricle contracts, some will go out to the body and some will go to the right ventricle, and it will go back out to be oxygenated. So a left to right shunt is always acyanotic. Now, if you have mixing that's right around where a vessel exits to the body, or you have mixing that has to occur in the PDA to be able to make circulation communicate with both sides of the heart, that's going to be a cyanotic disorder. And if you have any right to left shunting, so like with tetralogy of Fallot, you have that VSD, you have that aorta that's sitting right over the VSD as opposed to over the left ventricle. And so all that blood that's mixing right there is going out to the body. So think about what's happening with your mixing and your shunting. And then heart failure. Some of these heart defects can cause heart failure for these patients. So if you have right-sided heart failure, what's your symptomology? Right-sided heart failure. Yeah. Okay. You're getting a little deeper than I need you to. So it's going to back up where? Right. So then you'll have edema, periorbital or in their extremities. Right now, if you have left-sided heart failure, then what? Lungs. Yep. Crackles. Cough. Yep. We're done. We're like done in 30 seconds. So stay. Sorry. And then let's see. We talked about the TET spells. Okay. Remember knees to chest, or they squat down, and then remember your murmurs. Like, you don't have to remember if it's a systolic, like an ejection fraction kind of thing, or if it's a systolic murmur as opposed to what was the systolic? There was another one. I'm trying to think of the two. And you don't have to classify your murmurs, okay? But do know the location can indicate where the problem is. So if you have a murmur here, is it going to be tricuspid? What's the spot? Right. It's your aortic. Okay, so it's not going to be a tricuspid valve issue if you're hearing a murmur here, right? It's going to be an aortic valve issue that's coming off this side. Okay, so think about your names and your locations. Okay, so Friday at 9, I think I'm going to look at my planner. So watch your canvas for your announcements. We'll do a quick little 15-20 minute walk through the objectives Q&A. Okay, Miss Vicki, take a 10-minute break while she loads up her stuff, and then come back. Okay, and she's going to start a new conference, and it will be adult disorders, right? Yeah, adult cardiac disorders. So log off and then log back in. All right. Thank you. Bye. I love you. I love you too. That's true. I love you and I love you. I don't even care. My blue button friends, you got all the love, and my friends here in the classroom are very jealous.